Okay, so welcome. Today with the PQC Vermont Educational Webinar Series, we are going to be talking about perinatal vaccines. So this will be presented both by Dr. Marjorie Meyer as well as Katie Mahuron, which I don't think I said that correctly, so I'm so sorry. I know we just practiced. And before I turn it over to them, wanted to do a few housekeeping. So we ask that you use the chat to type in any questions. We are going to be holding questions until the Q&A section at the end, since we're sure there's going to be quite a few about this topic. Wanted to let you guys know that you should be muted when you come into the meeting. If you wish to verbally ask your question during the Q&A portion, please feel free to unmute. You can also utilize the hand raise function if you would like. And then also we have captioning for this. This is automatic captioning via Zoom. So if you go to the More section at the bottom of your Zoom, you should be able to find the show captions. And then also before leaving, there is a very quick 4-question evaluation. And so there's a QR code here. We'll share that again at the end. And of course, if you all haven't already, we would love to have you join the listserv for the PQC. So the email is there, so you could just email us and we will add you. So of course, I want to call out our collaborators. We wouldn't be able to do this without our partners, so thank you all. We have no disclosures. All right, so at this point, going to turn it over to Katie.
Thanks for having me. As was said, I'm a nurse with the immunization program at the health department. Next slide. And so I was asked to come today and speak a little bit about the public health perspective about vaccines. You're probably aware, but there's a lot of things happening right now in the immunization world. So I am going to try and give some background information about the immunization landscape, and particularly about that context within Vermont. And then I'm going to give some quick updates on respiratory virus vaccines and move to some public health messaging about the Hep B birth dose, and then try to do some quick takeaways. And I'm going to go fast because I want us to have time for questions after Dr. Meyer presents. Next slide. So this is my immunization landscape 102. It's a little bit more than 101. Next slide. So elephant in the room here, not a normal respiratory virus season, and the vaccine landscape is not business as usual. Next slide. So a little bit about why things are abnormal and why I'm even bringing this up. As you probably know, we normally rely on the ACIP, or the Advisory Committee for Immunization Practices, for our immunization recommendations each respiratory virus season. The ACIP voting members are independent medical and public health experts appointed by the HHS secretary, and they do not work for CDC. Their role is to review the scientific data and to provide guidance on which vaccines to use, when to administer them, to which populations, and the appropriate dosages. In June, Secretary Kennedy fired all of these ACIP members you see on the left, and this has traditionally been an apolitical group of public servants from the scientific and medical community. They've served their terms independent of changes in the presidential administration and CDC leadership. So Secretary Kennedy appointed 12 new members, shown here on the right, 5 of which were just added this month. Many of the panel's new members don't have deep current expertise in vaccines. Several of the new members have publicly questioned aspects of vaccines, and collectively their experiences are quite varied. We have some clinical pediatric experience, biostatistics, supply chain analytics, anti-vaccine advocacy, emergency medicine, obstetrics, industry strategy, lifestyle medicine, and neurodevelopmental research. So you might be wondering why I'm talking about this or why it's important. And the reason is not just because as healthcare professionals, we rely on the ACIP for clinical guidance, but also because much of our public health system infrastructure is also built on those recommendations from ACIP. Things like health insurance coverage, some states' scope of practice for pharmacists, and federal safety net programs can all be tied to the ACIP. So I'm just going to say up front that I'm trying to walk carefully a line here that keeps that balance between we can recognize legitimate concerns regarding this new ACIP and also recognize the institutional public health structures that are still really currently embedded in our daily work, in our insurance, and in our public health systems, and where we're seeing those changes this season. So I do want to say before we move on to the next slide, for the immunization program, our guiding star remains our belief that Vermonters deserve access to vaccines and to good information to make decisions for their families. Next slide. Okay, so because things are so complicated, I'm going to try and do a really quick overview of some basics and information about our vaccine infrastructure that'll help hopefully with this confusion. Because I don't know everyone's understanding of vaccine infrastructure. So for perspective building, this is a really lovely illustration from your local epidemiologist showing our normal fall respiratory vaccine process. Normally we have each of these different steps that's listed in a bullet point, and I'll just say nothing went strictly as normal for flu or COVID-19 this year, but the widest deviation was our COVID-19 vaccines. And as of September 30th, most of these things actually happened, even for COVID-19, but they were out of order from our traditional time frame. There were some deviations from the norm, such as that FDA tightening of the populations for COVID vaccine licensure, which you might have heard about in the news. I do want to point out that this circle that's here has not yet happened. So in Vermont and in most states, it is normal for pharmacies to receive their vaccines first. And they often have that actually written into their contracts that they get first access. But what's new this year is that wide timing between when we first saw those COVID-19 vaccines appear in pharmacies and when we're seeing our primary care offices have it through state supplied vaccine. And the reason why is this here circled. We can't get our state supplied vaccine until we have the sign off by the acting CDC director on ACIP recommendations. That sign off makes ACIP recommendations official. And traditionally, we've seen that happen pretty quickly, sometimes within a few hours, and other times it's a week after that ACIP meeting. But this new administration has shown that they can take a lot longer to do that after their last meeting. So next slide. Okay, so we talked about the national landscape, and now before I move into a brief overview of the recommendations, I want to make sure everyone has a quick overview of how the immunization program in Vermont works. So Vermont is a universal state for vaccines, with all of the vaccines for enrolled providers in the program receiving vaccine at no cost that can be used for patients regardless of their insurance status. And I want to point out that OBGYNs can be enrolled in this program, primary care providers, and birthing centers. And we do have birthing centers and OBGYNs enrolled. But if you are on this call and you are not one of those and you are interested, please reach out and we can walk you through that process. But I'm going to tell you more about this program and how it works in Vermont. And so this program is possible through 3 sources of funding, our universal program, through VFC funding, Section 317 funding, and insurer funding. VFC, or Vaccines for Children, is a federal vaccine program that provides funding to the department for eligible children and adolescents that can be used to purchase vaccines on the CDC contract. This funding can only be used to purchase vaccines on the CDC contract. So if a pregnant individual is under 19 years old and they're on Medicaid, they would qualify for a VFC vaccine. A second, significantly smaller part of that funding is the 317 funding that's provided by CDC. It's funding specifically for the purchase of vaccine on the CDC contract for uninsured adults and for outbreak response. And so in Vermont, what's unique because of our universal program is we supplement those 2 funding sources with insurer funding. The insurers pay an assessment fee for each covered life, and that money goes into a big pool of funding that we use to buy vaccines at a lower price through the CDC contract. So essentially, we have the 3 sources of funding that we pull together to purchase vaccines that enrolled providers can then order at no cost and administer to anyone without having to charge them or their insurance the cost of the vaccine. Our pediatric vaccine funding is basically split 50-50 between the VFC federal funding and the insurer funding. For adults, about 90% of our funding for state supplied vaccines is through insurer funding. And I will just say that Medicaid does not pay into the VVP pool of money for pediatric covered lives because that's where the federal money comes in, but they do pay in for the adult covered lives. So some important caveats to this program is that it is currently tied to ACIP recommendations and state statute. And importantly, one thing that I haven't said yet is these vaccines are included in the VFC program and in the Section 317 funding based on that ACIP recommendation and vote. So the ACIP votes are there to include or remove a vaccine from the VFC program. So this is why I talked about the ACIP, and you can see why the ACIP recommendations have a critical role in that current public health structure and our ability to continue offering and distributing vaccine. Next slide. So might all need a big breath after that context, but I just want to assure you that there are a lot of things happening at the state level, at a regional level to support vaccine access landscape in Vermont. So even if what I said might sound scary, in Vermont, the immunization program and department leadership are really actively engaged in planning, coordination to respond to everything that's happening. There's efforts and works to change that state statute to provide more flexibility. There's contingency plans for ordering and purchasing. Conversations are being had on a regular basis with partners at the state level, including state insurers and Medicaid, to make sure there's ongoing support for billing and funding if needed. And we've seen statements at the federal level for insurers' commitment. And most importantly, in that last bullet today, the health department has issued respiratory virus vaccine recommendations and standing orders for pharmacists to ensure access to evidence-based respiratory virus vaccines for all Vermonters. Next slide. Okay, so we talked a little bit about the vaccine landscape specific to access and the changing federal public health institutions. Now I'm going to pivot a little bit about a different part of the vaccine landscape, but that's specifically the importance of vaccination during pregnancy. So immunizations during pregnancy are unique in that they offer the opportunity to not only protect a vulnerable population due to those physiological changes that happen during pregnancy, but they also provide protection to the infant through passive immunization. So as you're aware, several of the vaccines administered during pregnancy, especially during respiratory virus season, are administered to offer that dual protection to the pregnant individual and the infant. So also from a public health perspective, I not only want to highlight the importance of vaccinating pregnant people for those protective factors, but I really want to talk to you about hardwiring a lifelong habit for immunization. The decision to vaccinate or not vaccinate during pregnancy can start a family's journey on their approach to immunization for their child's entire lifespan. So making sure that pregnant individuals are able to have positive vaccine conversations with trusted individuals, such as their healthcare providers, is really important. Next slide. So we do have some recent research from Emory University that really talks about this, showing that 48% of first-time expectant parents were undecided about vaccinating their children with all recommended vaccines. And then this percentage of uncertainty dropped to 18% for those with previous pregnancies and 4% for parents of young children. So this data is really demonstrating that parents are still making decisions about vaccines during pregnancy, especially that first pregnancy. And this is really a critical period for education and making sure they have a trusted source. Next slide. Okay, so that's my landscape here. Let's jump into it, starting with our respiratory virus season vaccine updates. Next slide. So respiratory virus vaccine immunizations are really a key part of our recommended vaccine panel during pregnancy. So I'm going to quickly review those recommendations. Next slide. And I'm going to be pulling from this from our Vermont Department of Health Respiratory Virus Vaccine Recommendation HON. These were made by the health department leadership through review of the science and recommendations of professional organizations and national partners like CDC, AAP, ACOG, the American Academy of Family Physicians, and Infectious Disease Society of America. Next slide. Here's a visual of our recommendations, and essentially everyone 6 months and older, unless contraindicated, should receive an updated flu and COVID-19 vaccine. And then anyone that's eligible within the certain categories should also receive RSV protection. And you can see in this visual, which is part of the reason I'm sharing it today, there's a special call-out box for pregnant and lactating individuals with a clear recommendation to vaccinate. Next slide. So starting with that protection for infants from severe RSV, we still have the two different ways to provide protection, so maternal vaccination or a monoclonal antibody. What's new this year is, as you may be aware, is we have a second monoclonal antibody, clesrovimab. And next slide. So here's a quick review of the similarities and differences between those two monoclonal antibody products for that first season. I'm not going to read these out, but the similarities are in green and differences are in red. And I should just note that for clesrovimab, it's only approved for first season use. So during a second season, if you had a high-risk infant, they would need nirsevimab. Next slide. And then, of course, being from the health department, we love to bring our data on how we're doing. So here's our RSV immunization coverage data for the 2024-2025 season. This is looking at protection through either doses administered to the pregnant individual or a monoclonal antibody after birth. And we saw an amazing increase at the statewide level in this second year. Next slide. Okay, moving on to influenza. This year, the vaccines are trivalent again. Next slide. And there's a recommendation for pregnant people to receive a vaccine at any point during pregnancy. This slide has some information about preferred timing, but I'm not going to review that in detail. Next slide. So I think for most of you, this isn't new information, but I really just want to emphasize again that importance during flu vaccine, that we're not just protecting the pregnant individual from those severe consequences of flu during pregnancy, but also protection of the infant after birth. Infants cannot be vaccinated for flu until they're 6 months old. So that passive immunity is critical. And there's really great research. And this is just one example about the robust protection offered during pregnancy through the passive immunity. Next slide. This data is a little bit dated because it's on a bit of a delay, but it's from PRAMS, and you can see our coverage rate for pregnant individuals is higher than the national average, but we still have some room for improvement. Next slide. Okay, so I'm going to dive into the messy world of COVID-19. Just want to recap that there is an updated vaccine and it is monovalent. Next slide. I don't think I need to tell you guys this, but pregnant individuals are one of the high-risk populations for COVID-19. There's an increased risk for hospitalization, and there's just risk for complications such as preterm birth or stillbirth as well. So we really want these individuals to be vaccinated and protected. Next slide. And again, COVID-19 is one of those vaccines where we're really thinking about that dual protection and the passive immunity that will be protected, passed on to the infant. So like flu, infants cannot receive COVID-19 vaccine until they're 6 months old. So we're really relying on passive immunity for protection. And you can see here that children under 6 months old have the second highest rate of COVID-19 hospitalization. Next slide. These are the COVID-19 vaccines that are licensed this year. If you are enrolled and receive your COVID-19 vaccines through our program, I'll point out that we will not have the mNEX spike this year, but we will have Spikevax, and then of course we'll have Novavax and Pfizer. Next slide. So I'm not going to go into this in detail, but I really just wanted to share this chart as a visualization of some of the confusion that's occurring around COVID-19 vaccine for pregnant individuals, because you can see the differences in these columns. And to be clear, I think what's really important is the science behind COVID-19 vaccines has not changed, nor has any new information on vaccines, benefits, or risks been identified. Next slide. So forget all that I just showed you about the confusion and lean into the Vermont recommendations here. And this is what you can hardwire, that there is a recommendation for everyone 6 months and older to receive an updated COVID-19 vaccine, including pregnant individuals. It can happen during any trimester and no need to delay pregnancy after a vaccine. Next slide. And again, because I find it helpful, I'm just putting this visual up here for your reference, and it is available on our website. Next slide. Okay, I'm switching to Hep B birth dose. Dr. Meyer is going to provide some additional clinical updates and information that's really important about Hep B guidance during pregnancy, but I'm going to focus solely on that Hep B birth dose because we saw this come up at the ACIP meeting. So I'm going to talk about that. Next slide. At this month's ACIP meeting, the Hep B birth dose was on the agenda. I'm not going to go into the details of the discussion or the inaccuracies that were presented, and there were a lot. But as I mentioned earlier with this new ACIP, we're really seeing a radical change to how federal vaccine policy making is occurring, and this was a really good example of that. No new evidence was available on the safety or effectiveness of the Hep B birth dose. This was just a clear example of committee members coming in with an agenda and then trying to find some evidence to support their preferred agenda. So for the ACIP votes, we saw them vote that all pregnant people should be tested for Hep B infection during pregnancy, something that's already standard of practice and really not the scope of the ACIP. And second, they voted to table any changes to the recommendation regarding the Hep B birth dose schedule. So they had a second potential dose or potential vote, and they voted to table it. Next slide. So where does this leave us? And frankly, it leaves us with a bit of confusion. We've already heard from some of our providers and the public who are unsure what the outcome was in terms of Hep B birth dose and if it impacted them because they saw things in the news. So I just want to be clear, nothing changed. There's still a universal recommendation for Hep B birth dose. Next slide. And the science has not changed. This slide demonstrates so critically why that universal Hep B birth dose is so important. The risk of chronic infection is heavily weighted onto infants. If an infant's infected during their first year of life, they're 90% likely to develop chronic infection, compared with 30% of children infected during 1 and 4 years, and less than 5% of infected adults. And we know that chronic infection has real consequences such as liver damage, cirrhosis, liver cancer, and even death. Next slide. And again, here are our state rates within a day and 3 days for Hep B birth dose. So you can see there's room for improvement here because we're really going for universal. So 100% would be the goal protection. Next slide. Okay, so I tried quickly to cover the landscape, the updates for respiratory virus and ACIP. I want to just do a few quick takeaways that I hope will be helpful. Next slide. The first is about the vaccine access landscape in Vermont, and there are currently no major impacts. We are currently waiting to get access to that 2025-2026 COVID-19 vaccine, but we are really committed to ensuring vaccine access, and we're not seeing changes in that access in other ways. Next slide. And then I also wanted to share about this messaging. So what we're hearing and learning from our national partners is on an individual level, when you're talking to patients, we're really trying to frame vaccines as our best defense against severe disease, our best defense to protect ourselves or your child, instead of saying things like vaccines are safe and effective. So yes, there is the science around safety and efficacy, and we can think about that as healthcare providers and really feel comfort in all that. But for an individual level, that pregnant individual who's thinking about their infant, safe and effective are subjective. So we really want to lean into the messaging that this is your best defense against severe COVID-19. This is your best defense against flu, or this is your infant's best defense. There is a proven track record for vaccines of reducing disease, and that's kind of the messaging that we want to move to on an individual basis. Next slide. So I'm just going to say that as a healthcare professional, amidst all the uncertainty, I think this quote from your local epidemiologist, Caitlin Jetelina, is really helpful for us to hold on to, and that is the science is strong. Vaccines work, they save lives, and they're very safe. So when we're trying to have those difficult conversations with pregnant people, and it takes lots of trust building and conversations, we can anchor ourselves to the statement that it's important to have that conversation because the vaccines work and they're safe. Next slide. Another bedrock I just want to share for a key takeaway, vaccines are still the social norm. We see this in our high coverage rates in Vermont and in national data. And frankly, at the health department, we have seen an influx of emails and calls from practices and the community seeking COVID-19 vaccine. So we know that it's still the social norm in Vermont. Most Vermonters are choosing to protect themselves through immunization despite social media naysayers. And next slide. Promise I just have 2 more of these and then we'll wrap it up. So we believe that investing in trust is in investing in immunizations. We're living in a time where daily events have potential to erode trust in immunizations, and that could have devastating impacts on our overall protection against preventable diseases. We want people to be protected, but ultimately that decision is theirs. So that trust between providers and family is key to increasing our immunization uptake and empowering people to make a decision that's best for them. So of course, just listening to their concerns, addressing misconceptions, and demonstrating cultural sensitivity are always good investments. And then next slide. So my final slide that I want to talk about is just confusion leads to inaction. So that's why I came today, is hopefully to help with some of the confusion. People don't need to be persuaded against vaccines to not get them. They really just need to be confused enough to not make a decision. So as healthcare professionals, we're educators, we're empathetic and compassionate, and we believe in the science, and we have that knowledge to decrease and even eliminate confusion. So in the current landscape, it probably is just going to take more time, but please don't give up, especially for these pregnant individuals, which are so critical for setting up our vaccine trust. So continue educating, continue building the trust and sharing the science. And that is it. I have some resource slides that can be shared out for later, but thank you.
And I will be sending out these slides with clickable links of all of these resources. Okay, Marge, over to you.
Great. Well, that's awesome. And honestly, some of these things are going to be redundant, so I'll equally go fast. And I have to say that I find our vaccination rates actually remarkably good. We we do seem to be a pretty accepting state in that regard. But there are a couple of updates I just want to clarify. Next slide, please. So this is just to remind people why the maternal vaccines work. I know that I probably at least half the time when I'm talking about a DPT, pertussis vaccine, I have to explain to the patient what exactly is going on. And remember that maternal IgG, that's the immunoglobulin, crosses the placenta, and that is actually that's how the baby gets its passive immunization. And so Tdap is basically just a booster for the mom to increase the IgG concentrations to go across. And that passive immunization has been demonstrated to work very effectively. I do think that making sure that you understand this so that you can help explain to moms why why her vaccination matters to the baby is super helpful. The other thing that's helpful to remember, though, is that the IgG transfer requires a good amount of IgG and it requires some time to get across. That's why a vaccine given at 36 weeks is not going to be as effective as a vaccine given earlier, but that's why we give them in that later part of pregnancy, not the super early part of pregnancy, because IgG doesn't cross over very well. Next slide, please. So we have a bunch of neonatal infections that pregnancy is like geared to deal with a number of infections. I'm going to mostly talk about Hep B and RSV today. Next slide. So Hep B. So I think that, we've already just heard about hepatitis B in pregnancy, but there are some new things. And there's a webinar that is only devoted to Hep B on the website, just so you know. Next slide, please. I think one of the striking things is the prevalence of hepatitis B. Our patients really, I know it seems like everybody just lives in Vermont, but in fact, people are coming from all over, and there are places that have very, very high rates of hepatitis B. It's also a communicable disease. So if people are in touch with other people that are in these higher prevalent places, you're more likely to have Hep B. So many people might think, oh, I can't get Hep B, my kid can't get Hep B. Well, that is not true because both are around and may be exposed to it. Next slide, please. So the main reason that screening matters is this issue of how old you are if you get it. And the biggest problem with infection is this issue of the newborns because they get chronic disease, and it's that chronic disease that is particularly dangerous in terms of not just liver failure, but also hepatocellular carcinoma. About 50% of the cases worldwide are related to liver cancer. Also, remember, about 2/3 of people are not aware that they are carriers for hepatitis B. In the US, sexual intercourse and IV drug use are major contributors. Worldwide, it is related to birth. And the recommendation is that all adults get screened, but we know that not everybody has a PCP, so our screening is not particularly effective. For prevention, there is a recommendation for universal vaccination, and of course, there's this focus on neonatal vaccination. Next slide, please. So the CDC and the ACOG recommendations for adults are that all adults should have this triple screen. That means you get the antigen, the anti-hepatitis B surface antibody, and an anti-hepatitis B core antibody assessment. Now, we know that this recommendation is relatively new. It's just from 2023. So most of our patients that are coming to us pregnant will have never had this triple screen. So we are the ones that can see them for the first time so that we can identify them. Using these things, we can identify who's a carrier, who is susceptible, who's had it before, and who might benefit from vaccination. There is no need, though, for pre-vaccine testing. The screen is really mainly to identify people in need of treatment. And you don't need to do post-vaccination testing to make sure it sort of works. There are 3 specific vaccines that you can use, and pregnant providers, and I think we don't do this very much, really should identify people who are susceptible to hepatitis B and who would benefit from the vaccine. And these are the vaccine combos that are recommended. Next slide, please. So this is, I'm not going to go through this whole slide because each thing, but it has to do with how you can interpret once you get those antibodies back about what their status is. The most important thing to identify are the people that I've highlighted. People that are infected with hepatitis B, so that you can, I'm going to get into this, treat them and protect the neonate, and people who are susceptible to hepatitis B. And those are the people that we need to vaccinate during their pregnancy. Next slide, please. So vertical transmission is defined as transmission that happens during pregnancy from mom to the baby. Again, the most important reason for this is because of the chronic nature of hepatitis should the newborn get infected. The interventions that we have, that would be hepatitis B immunoglobulin and the vaccine, both prevent neonatal infection and are critical. Next slide, please. The other important piece to remember is that in people who are carrying hepatitis B, their viral load matters. And so another important take home is to know what the viral load is and to know that there is a treatment that is available for pregnant people to get their viral load down to reduce the chances that the baby would get hepatitis B infection from a transmission from mom to baby. Next slide, please. So you do not have to know anything about this slide except for to know that if moms have chronic hepatitis B, that is their surface antigen is positive, get a viral load. If that viral load is high, or if it's even positive, ask somebody. There are certain levels at which we would treat people in pregnancy. There's very good data about reducing the transmission in people who have very high viral loads so that maternal to child transmission does not occur. And I just want to remind people, it's not just vertical transmission that happens in utero, but also after the baby's born. That baby is at risk for getting infected by the mom from the usual body fluid contacts. Next slide, please. Breastfeeding is not contraindicated in people who have hepatitis B. There's no difference in infection between breastfed and formula-fed people, so people with hepatitis B can breastfeed. Next slide. So in summary, basically, identify the people who have an hepatitis B infection and vaccinate during pregnancy those people who are susceptible, and if they choose to not be vaccinated during their pregnancy, try and convince them to be vaccinated after delivery. Next slide, please. So what about RSV? Next slide. Now remember that RSV provides antibodies in a similar way to pertussis. Mom gets the RSV vaccine, creates antibodies, so antibodies cross the placenta and protect the neonate. The most important thing for this year that is new for this year, because we've only had RSV vaccine for 2 years, is that if they have had an RSV vaccine in a prior pregnancy, they are not a candidate to get the maternal RSV vaccine in this pregnancy, but that baby, that neonate, does need to get the neonatal protection just like it normally would. And that's because they've just not done the studies to make sure that the mom's antibody response is high enough to protect the neonates if they've had the RSV vaccine before. So with patients that have never had an RSV vaccine, we have a conversation with people that say it is your choice. You can have the maternal vaccine, or you can have your baby get the neonatal vaccine. For people that have had RSV vaccine in a prior pregnancy, the only option and recommendation is for that neonatal, well, it's not really a vaccine, it's a passive antibody approach. Next slide, please. So again, this is just, I didn't add in the new antibody because I didn't know that there was one till today. So, but remember, again, this is just the one slide. Do not use the RSV vaccine if they've had it in a prior pregnancy. Otherwise, people can choose. Next slide, please. This is just a reminder about how well passive immunization works. It's just remarkable. Pertussis is a great example of really a public health success. You can see how rare whooping cough is, thanks to TPT. Next slide, please. So again, we have a lot of neonatal infections that are amenable to screening and intervention during pregnancy. It's super important to follow all of them. Next slide, please. And lastly, I just wanted to touch on this issue of acetaminophen in pregnancy. I can't emphasize enough how much, I don't remember where I read it, but I read that patients, if you ask them in general, they say they don't trust healthcare providers. But when you ask people that are talking to their healthcare provider at that time and like, well, but do you trust that provider that's sitting in front of you? The answer is almost uniformly yes. So it's critical that we initiate conversations, because even though people, there's no question that trust has been degraded in the patient and provider relationship. My suspicion would be that your personal relationship with that individual patient is probably still intact. The acetaminophen data in pregnancy is just like some of the vaccine data. There are no new data that are concerning. There are plenty of resources, and I put them up here. And I asked, Sam got the files to put into the chat. So patients ask you about using acetaminophen in pregnancy, you can have those conversations, say, the data overall are weak, and there are no data about causation. But I realize that conversations with people in the moment can be very difficult. That's why, again, this patient-facing sheet from ACOG is pretty good. There's another provider-facing sheet that's from ACOG, and I have the ACOG clinical guidance practice and advisory for acetaminophen use, and I have the Society for Maternal Fetal Medicine statement on use. It is always helpful to reflect why people are taking the acetaminophen to remind them that fever in pregnancy is not particularly good either, nor is untreated pain. And it's super important that remember this link between maternal health and newborn health and even childhood health is very strong. So the strongest, the healthiest mom is going to give you the healthiest baby and the healthiest child. So I just want to encourage you to have those conversations. Next slide, please. So I did want to make sure that we had plenty of time for conversations, and to let you guys know that we're here as a resource for you. And I know that there are a lot of other things that are going on in the landscape in obstetric care in general in the state, and we're happy to chat really about anything that is on your mind, because there's so much other navigation besides science going on in what we're doing. So I think we can just open it up now. Sam, is that right?
Yes, I was going to stop sharing so that we can actually see each other, and then also so that I can see the chat to bring those to you guys. All right.
Thanks so much, Marge. Hi, everyone. It's Brina. I'll get us started. I really want to hear from you all. You've got Marge here, you've got Katie, you've got others from the Vermont Department of Health. It's very helpful in Vermont for us to hear what you're experiencing. So what are your patients saying? What I see some of my home health colleagues, what are the conversations that you're finding yourselves having to have despite the science just not backing up what people are worried about? That's where I'm interested today. And I just wanted to also acknowledge I'm so sorry because it's exhausting. It's already hard out there. And then you add this layer of having to uh, address a myth. It's just, it was already hard. So Tylenol does not cause autism. Like that's just plain and simple. But I also think Marge and her team have been a champion for this concept on the earth that we're not really that good at valuing pregnant people and children. And this adds shame and a complete disconnect from the importance of autonomy in pregnancy and also the privacy of your conversation with your healthcare professional. So what's it like for you out there? Those of you in real life.
People asking you guys about vaccines. I know that I can tell you my experience is a little disheartening, because I personally find that patients are just coming and saying no. They're not even asking me anything. I often will provide a brief explanation just about why they work. I don't explain to them why they should have a vaccine or not. I simply explain how it is that their vaccination is helping. I don't know if it matters. Occasionally I'll have somebody accept a Tdap that's declined it, but it's funny because the Tdap seems to be, people are more hesitant. We had a huge amount of people asking last year, especially about RSV. They already started asking about RSV, but in a different way that whooping cough is. I just find it curious, but.
All right, so we do have one comment in the chat. So I just say delicately and respectfully, approaching parents who are against all vaccinations. All right, and I see Melissa, you have your hand up.
Yeah, I would say that, so the positive is that there are lots of people who, it's kind of binary. there are a lot of people who don't question they're 100% vaccinating their children. They're not thinking it's not, this misinformation is not making a dent. So yay. But certainly there are a lot of people, many of whom I didn't know before, so I don't know, you know, control group wise, what has influenced them, but it feels like since the pandemic, and all of the vaccination stuff around COVID vaccines, just more and more people seem to be, oh no, I would never do that. Not, I'm curious or I'm wondering or whatever. So definitely, particularly in home health, we do have that benefit of having regular contact over and over again, slow glacial pace behavioral change conversations in general. So the level of trying to build trust over time and I'd just like to have a conversation if you're willing, or that sort of slow paced. I would say I have not had more than a handful of people go from being opposed to using our relationship and long-term education and support and respect and trust to convert into being willing. But occasionally it has happened.
Great, Melissa. Thank you. Home health is a cool space. If you think about that consistency and the opportunity for multiple conversations, whereas a medical practice, not quite as frequent, although the beginning of life, you do have a bunch of checkups.
But
I
a
did have
thousand
great,
other things to, a
yeah,
thousand
of
other
course,
things to,
right. No,
right?
that's the part I can
So,
feel so deeply is the fatigue of it all. Like, so I was trained by a really cool primary care guy that said a good way to approach these conversations is to start by asking a family, who are you talking to about your baby? Like, where are you getting your input? What is your source of information for your baby? And that's when you learn what's going on. The news, TikTok. We did the AAP showed data this summer that before the pandemic, about 17, 18% of people were getting medical information on TikTok, and it's now over 50. 50% of humans getting information on TikTok. So the AAP's approach to that was to pivot and start going on TikTok, join them. Pat, I see your hand up. Hi, Pat.
Hey, Brina. So I realize I'm looking away from everyone. So I have been doing it is a very, not anything that I would ever share with data people, but like a little survey that I've been doing with WIC families that have come into WIC. So I kind of follow up on all the WIC children that are behind on immunizations and their reasons for being behind. Either we just don't have the information, or there's historical information we never got. They moved from another state, all sorts of different reasons. But what I've noticed in the last year or so is an increased number of families that that decide not to immunize at all or stopped immunizations. And it's seemingly coming up. So I looked at the last 6 months of the kids that had come through from January to June of this year. And I've had 41 families that I was following up on. A lot of those I didn't have releases, so I couldn't get their information from providers that might just have historical data that's not there. But out of the 41, 10 of those have said that they refuse to immunize or are no longer immunizing their kids, or they're being selective about what they pick. And it just seemed like that number has increased more so in the last couple of years. And it's very disturbing to me because I don't know how much is misinformation or or just, the fear that's out there. So I I just wish we could do a better job of informing folks. And I don't know if our hands are tied about a lot of this misinformation, because I hear in the news all the time about, acetaminophen causes autism and stuff, but I don't see a lot of that other talk, like, like this is not true and these are the facts. So I
Well, we can
wish
make sure you get those, Pat, because what we've been circulating has been really gratifying, which is ACOG, AAP, AAFP, Association of Psychiatry, everyone's saying the exact same thing. And so all of those links and statements we can package up, or Samantha maybe already has, just so you have like your treasure trove, because you have to find your own rhythm and style too, because some just handing people pamphlets and links and stuff isn't proving to be helpful, but it's nice to sort of see what's the language. The developmental behavioral pediatricians got out ahead of this years ago. They noted this piece about folic acid and whether kids needed leucovorin as a way to treat autism, and they have a nice statement about that not, not being studied properly and not actually meeting the standard of care. So yeah, I think we're better than we used to be. I agree. It used to be pretty, how do I keep up? But now we've got sort of professional organizations keeping it nice and simple. It's just not true.
But Rita, what I'm thinking of is in
Yeah.
terms of, I mean, it's great. As a health department, as working in the health department, we get that information. It's the general public that's not getting that information. Someone's not gonna, a general person, like I can speak to some members of my family that, aren't gonna go look up what, what the blah 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 said, so it's just they hear it kind of word of mouth, and that's where I don't know the right messaging we can give out to folks, but
Yeah, I
just on
hear
the
you on
platforms
that.
that they
Yeah.
use.
And Pat, I think that it's super hard, but I'm coming back to the difficulty of trust, and I think a lot about how we sort of just educate people, and I just explained all these ways how I try and educate people in the office, but I don't do it to for them to understand the mechanics of how antibody transfer works. I do it to see if it's a way to bridge some trust that there's other information behind these things other than yes or no, but I see it. I feel like if it was simple as just information, we probably wouldn't be here. If there is something else that's going on that has really gets between us and our patients, that is that for whatever reason they're choosing to believe what they see on TikTok more than
Right.
what we say, and I don't know the way.
Well, you just hit on it
around
beautifully, Marge, that folks in the chat are so lovely. These
Yes,
is like,
I wanted to make sure we
yeah,
give time. We have at least three
sure.
in the
You want to
chat.
read them, Samantha, or do you want me
I
to?
was gonna see if Jennifer, I think yours is the next in line. Would you like to unmute and
Hi,
speak?
everyone. Yeah. Our providers, I'm in on some of their conversations, just supporting each other around we care about patients. Like you're saying, it's about trust, it's about relationship. And one of our nurse midwives said something that she's saying, like the phrase, like respectfully, in my profession and in my training, the science says vaccines are best defense. Like I love that language. And so she's saying something like that and was sharing that with other medical providers, and also added something about like, I have a liability, I have a license, I have, this is my profession, that I would not give any recommendations or support patients that would put that at risk. This is my life work. So there was something about that. not in a defensive way, but in a respectful way. And then we have residents here from UVM Larner School, and so they're more on TikTok than some of us older folks are, as they're sharing some of the humor just to support each other, not to be disrespectful at all about families who have family members with autism, but just to highlight for ourselves, yes, there is hypocrisy. Yes, there is clashing of information. And okay, we got to swim through this steady somehow. So that was my sharing. Thank you so much.
Thank you. And I also see Amy, I think you're the next one to write in the chat. Would you like to unmute and speak?
Sure. I think, like Melissa said, in home health, we do have a really good opportunity to sit with families and really have those conversations and over again. And so, we do a lot of normalization on how hard that choice is to vaccinate themselves, because and use that as an opportunity to praise them for questioning, and because that's parenting. And we kind of link that to these are those first decisions that you have to make for your kiddo that are really hard, and let's talk about it, and then get really curious about what their concerns are and where they're getting their information. And I really love that the CHOP website, because it's so patient friendly, and we were able to get the materials from the VDH, which was great, which we're going to use with our clients. But I think with so much conflicting information out there, it's unfortunately become so political that it's like we have to kind of take a minute to push the politics out of the way as well when we're having these conversations, to get to that normalization and be able to kind of bring it down a notch. So I think that's what we kind of spend more time doing these days as well, which is hard to do.
Excellent. Thank you. And then let's see, Heather, are you able to unmute and speak?
Hi. Yeah, I mean, I just think I talk a lot about vaccines and stuff, and part of it, I feel like I can leverage my background a little bit because I came from a family that didn't vaccinate. I came from a really right-wing, to this day, my parents are scared to death of anything the system, And to be able to really say, I know people are trying to make the best decisions that they can. They're trying to do the right thing. So when people be like, "Oh, I know, so don't get on Google." I'm like, I get on Google all the time. You just have to know how to sort out the good from the bad, right? And to really just, I guess that's my big thing, is really just, I talk to people about this a lot, and in my experience, it's not my goal to move them to what I want them to do. Like, that is really truly not my goal. My goal is to help them have the information so they can make decisions that they will not regret in the future. But lots of people change their minds after we've talked, lots and lots and lots. And I've, from where I practiced before, I worked with a lot of kind of fundamentalist kind of communities, and I always had families with pertussis running around. I always had a family with whooping cough, chicken pox, stuff like that. And I've seen both sides of it, and to be able to say, I've actually seen this. I know a kid who couldn't ever really breathe well after his 3 month his coughing summer, and it's like, it happens. And that's why we do it. And I really actually really like that, the phrasing of, is our best defense. It is, and being healthy and doing the other things. And I also, as far as the acetaminophen stuff too, I think it's really important to really focus on. We have excellent data from all sorts that says taking care of the mom is the best way to take care of the kids. And I really like to focus on that. That's all I have to say.
Heather, that's a remarkable way to end. Thank you for that. I wanted to empower people with something Marge said earlier. The Kaiser Family Foundation did a big study in May of 2025 that showed people really do trust their healthcare professionals. The trust is gone with FDA, Health and Human Services, the CDC, all the things. But the healthcare professional is still alive and well. So that's more work for you, but it means it's worth your effort.
Thank you. And thank you all for being here. Did want to just reiterate that we will be sharing the slides as well as the resources that have been mentioned in the chat. So look for that in the next couple of days. So thank you all. Have a great rest of your day.